For decades, some of the top sports medicine doctors in the world were essentially prescribing rest, anti-inflammatory drugs, and, cortisone injections to patients suffering from chronic tendon pain.
Right. They were fighting what they really firmly believed was this raging fire inside the tissue.
Exactly. But the crazy problem was there was no fire. Like they were treating a condition that literally didn't exist.
Yeah.
And in a lot of cases, their treatments were actually making the underlying tissue weaker. And all of this collateral damage, this massive medical misstep, it all stemmed largely from a linguistic glitch.
Just a 2,000-year-old misunderstanding baked into a single medical suffix.
It's wild. So, welcome to the deep dive. Our mission today is unpacking the medical terminology for the actual biological tethers that physically hold your skeleton together.
The roots tenno, tendino, and ligamento.
Right. And we're looking at how this seemingly, dry set of vocabulary words connects to ancient anatomical confusion, a multi-million-dollar sports medicine industry, and that famous failure in treatment we just mentioned.
Because it really is one of the most consequential examples of how the vocabulary we use to describe the human body can just completely override our clinical observation of it.
Yeah.
We trust our terminology so implicitly that, when the word says the tissue is inflamed, we treat the inflammation.
Yeah.
Even when the microscope is telling us something completely different.
Okay, let's unpack this. Because when you look at something like, say, suspension bridge, right? The engineering is incredibly clear-cut.
Totally.
You have massive concrete pillars anchoring everything into the earth, and you have these thick steel cables under immense tension holding the road up. A cable is a cable, a pillar is a pillar.
Right. Structural engineering relies on distinct materials with entirely different predictable properties. But the biological engineering of your body is it's entirely different.
The blueprints are covered in smudges.
Exactly.
Yeah.
The tissues that tether us together, that allow you to jump and run, they're surrounded by this incredibly murky linguistic landscape.
But before we get to the muddy waters, we should probably establish the textbook baseline. Because historically, anatomy has drawn a really clean line between a tendon and a ligament based on, well, what they connect and what they actually do.
Right. So the roots, tenno and tendino, mean tendon, which is the dense connective tissue anchoring muscle to bone.
Muscle to bone.
Right. So when a muscle contracts, the tendon transmits that pulling force to the bone, which produces movement. Meanwhile, the root ligamento, meaning ligament, connects bone to bone across a joint.
So instead of transmitting force to create movement, its job is more to restrict and stabilize motion.
Exactly. It acts as a biological check rein. It limits how far your bones can move relative to one another, so your joints don't just dislocate under stress.
Which functionally makes total sense. Muscle to bone is the pulley, bone to bone is the anchor. But looking at the sources we have for this deep dive, that clean distinction totally falls apart the second you put these tissues under a microscope.
It really does. Zooming in on the histological level, the cellular makeup of a tendon and a ligament is remarkably similar. I mean, they're basically built from the exact same raw materials.
Right.
Both are composed predominantly of type I collagen, which is the body's premier tensile material. Both are arranged in what we call dense regular connective tissue.
Meaning the fibers run in like organized parallel bundles?
Yeah, exactly. And both are populated by these spindle-shaped fibroblast-like cells, though we specifically call them tenocytes when they live in tendons.
So the primary difference just comes down to the really precise microscopic alignment and the crimp pattern of those collagen fibers.
Right. And because they're so structurally similar, major sports science researchers like Canis in his really widely cited year 2000 overview, they emphasize that tendons and ligaments are far more alike than they are different.
Wait, don't modern tissue engineers, like the ones designing synthetic grafts, don't they often just lump them together?
They do. They often treat them as a single biomechanical category, just tendon/ligament tissue.
Which means the names we assign them are doing a lot of heavy lifting. If the biological steel cable is virtually identical, the nomenclature has to be incredibly precise to tell them apart.
But the nomenclature is anything but precise. Anatomy actually routinely ignores its own textbook rules here.
Right. Reading this, it feels like they treat the word ligament less like a highly specific engineering term and more like a linguistic jump drawer.
That's a great way to put it. Early anatomists basically used the Latin word ligamentum generically for anything that seemed to bind one structure to another, regardless of what it was actually made of.
And we inherited a massive amount of exceptions from that era, right?
Oh, absolutely. Take the falciform and coronary ligaments of the liver or the broad ligament of the uterus. I mean, they aren't dense, fibrous bands of connective tissue at all.
Not at all.
They're simply reinforced folds of the peritoneum, the serous membrane lining the abdominal cavity. They don't provide musculoskeletal tension, they just loosely suspend organs.
And then you have the periodontal ligament, which completely shatters the fundamental bone-to-bone rule.
Oh yeah, that's a classic example.
It's the structure that anchors a tooth into its socket in the jaw. But a tooth, specifically the cementum layer on its root, is not bone. So the whole bone-to-bone definition is really just a first approximation that dental hygiene students have to immediately unlearn.
Which is funny, and it is worth clarifying here. If you are picturing cartilage right now, you should probably erase that image.
Yeah, good point. Cartilage is completely different.
Right, it's dominated by totally different cells called chondrocytes, and it's built mostly from collagen type 2, not type I. It acts as a shock absorber, or a smooth gliding surface at the joints, completely distinct from the tension-bearing tethers we're talking about today.
So to understand why this nomenclature is such a mess-like, why we have two totally different roots for tendon, tenno, and tendino, and why ligament became a junk drawer, we have to look at how these words accumulated over, 2 millennia?
Yeah, the linguistic tangling goes all the way back to ancient Greece. So the root teno comes from the Greek word tenun, which stems from the verb tanin, meaning to stretch.
Which makes perfect sense for a tension cable.
It does. The complication is that ancient Greek physicians didn't really reliably distinguish between a tendon and a nerve.
Wait, really?
Yeah, they used the word neuron for any tough, stretchy, cord-like structure they found during early explorations of the body. Tendon, ligament, nerve, it was all just categorized as a neuron.
That's wild. It's like if we use the word wire for both the fiber optic electrical cords carrying data and the structural steel cables holding up the roof of a building.
Exactly.
An electrician doing surgery would just have to guess which one to cut when they opened up the wall.
And you can imagine the surgical consequences of that kind of ambiguity. The shift towards separating them didn't really begin until the Alexandrian anatomists, Herophilus and Erostratus, working around 300 BCE.
Right, because they were among the first to actually systematically perform human dissection.
Yes, and that allowed them to visibly separate the sinews carrying sensation and movement commands, so the nerves, from the sinews connecting muscle to bone.
But even centuries later, like in the 2nd century CE, the highly influential physician Galen was still using overlapping vocabulary for these structures.
He was. And we actually have a fascinating linguistic fossil of that ancient Greek confusion still surviving in modern anatomy. The word aponeurosis.
Oh, right. An aponeurosis is like a broad, flat sheet of tendon, right? Like the glia aponeurotica under the skin of the scalp.
Precisely. And it literally contains the root neuron, but it's composed entirely of dense connective tissue with absolutely zero nerve tissue.
It's just baked right into the word.
Yeah. So we have the purely Greek-derived form, tendino, but the existence of the second root, tendino, introduces a completely different historical complication. And this one we can blame on the Romans.
Whoa, the Romans. How did we end up with tendino?
Well, classical Latin authors writing before the 3rd century CE primarily called tendons nervus, which is the exact same word they use for nerves.
Just that they were doing the exact same thing the Greeks did.
Yep. Which makes ancient Roman surgical texts incredibly treacherous to translate today. But by late antiquity, around the 5th century CE, medical writers like Caelius Aurelianus were translating older, more precise Greek texts, and realized Latin just lacked the specific vocabulary they needed.
So they just made one up.
Basically, they forged a linguistic hybrid. They took the meaning of the Greek tenens, but reshaped the spelling to mimic the Latin verb tendere, which also happens to mean to stretch.
That is wild. Etymologists actually consider this a remarkable case of two independently stretch-related terms converging.
It's pretty rare. So they invented the medical Latin word tendo and its genitive form, tendinus,
which gave us tendino, the Latinized form we see in words like tendinitis, sitting right alongside the Greek tenno used in words like tenotomy.
Exactly. And this dual vocabulary persisted for centuries. It wasn't until the Renaissance, notably with Andreas Vesalius's groundbreaking anatomical atlas in 1543, that anatomists started really tightening up the vocabulary based on direct dissection.
Rather than just unquestioned deference to ancient texts. But getting everyone on the same page, achieving true global standardization, that was like negotiating an international peace treaty for medical language.
It took a series of global congresses.
Yeah. starting with the Basel Nomina Anatomica in 1895, and arguably didn't finish until the publication of the Terminologia Anatomica in 1998.
2 millennia of debate just to agree on what to call the tissue attaching your calf to your heel.
It's incredible. Now, the root ligamento, by comparison, is incredibly straightforward.
Oh yeah, much simpler. It derives straight from the Latin ligamentum, meaning a band or bandage, from the verb ligare, to bind.
Right, and it permeates medical language in terms like ligature, meaning to tie off a blood vessel.
And there's also a heavily contested yet pretty profound etymological theory debated by ancient writers like Lactantius.
Oh, about the word religion.
Yes. Suggesting the word religion traces back to religare, meaning to bind oneself to the sacred.
It's a fascinating leap, right? From physical tethers in the knee to spiritual tethers. But bringing it back to the physical tethers is where the biomechanics become really vital, because function dictates design, and that design dictates exactly how these tissues fail.
Right. And the Achilles tendon anatomically, the tendocalcaneus, is the perfect illustration of this. As the largest and strongest tendon in the body, it has to transmit massive, rapid, unidirectional pulling force.
So to handle that load, its collagen fibers run in incredibly tight parallel bundles.
Exactly.
And the sheer physics involved are just staggering. In the 1990s, there was this Finnish sports scientist named Paavo Komi. He actually surgically implanted force transducers directly into the Achilles tendons of living human subjects.
Which is just an intense experiment.
Right. He wanted to measure the load during running and jumping. And he recorded peak forces in the range of several kilonewtons per stride. That is roughly 10 times a runner's body weight, bearing down on a single isolated cord of tissue with every single step.
Which perfectly explains the classic weekend warrior injury.
Oh, for sure.
The tendon is engineered for extreme tensile strength. But when an unconditioned person abruptly demands it to handle a load exceeding its current structural tolerance, it simply snaps.
And that massive tensile strength requires such dense packing of collagen fibers that there is virtually no room for blood vessels inside the tissue.
Right, which brings us to the critical difference in how ligaments heal. If ligaments trade massive, unidirectional strength for orientation-specific restraint to keep a joint from wobbling, their location and their blood supply completely dictate their recovery.
And the knee is the ultimate case study here, specifically looking at the medial collateral ligament, the MCL, versus the anterior cruciate ligament, the ACL.
Right, so the MCL sits largely outside the primary joint capsule. It benefits from a relatively robust, localized blood supply, so when it's torn, it frequently heals organically with just bracing and targeted rehab.
But the ACL is a completely different story.
Completely. The ACL lives entirely inside the joint capsule, submerged in synovial fluid. It possesses a notoriously poor intrinsic blood supply. Once fully ruptured, the lack of robust blood flow means the ACL essentially never heals on its own.
So returning to high-demand sports like soccer or basketball basically requires surgical reconstruction.
Yeah, and surgeons routinely harvest a graft from the patient's own patellar tendon, or a hamstring tendon, to build a new ligament.
Which is fascinating because it physically demonstrates how interchangeable these tissues are mechanically. A piece of tendon seamlessly becomes a ligament.
Right, and that reconstruction is performed hundreds of thousands of times a year in the U.S. alone, which points to a highly researched disparity in sports medicine.
You mean the difference in tear rates?
Yeah. Female athletes in high-impact sports tear their ACLs at rates 2 to several-fold higher than male athletes. It's a highly complex, multifactorial issue. Researchers point to anatomical variables, like a narrower intercondylar notch in the femur where the ligament sits, alongside hormonal fluctuations affecting ligament laxity and distinct neuromuscular landing mechanics.
And that structural reality, the poor blood supply, the slow healing, the sheer forces involved, is exactly what set the stage for the linguistic disaster we mentioned at the very beginning of the deep dive, the ileitis suffix.
Yes, this is huge. In medical terminology, ileitis universally denotes inflammation, right? Like an appendicitis or dermatitis.
Right. And for most of the 20th century, the clinical assumption was that chronic overuse pain in tendons was fundamentally an inflammatory process.
The diagnoses were tennis elbow, golfer's elbow, Achilles tendonitis.
And driven by that vocabulary, the standard of care became rest, non-steroidal anti-inflammatory drugs, and corticosteroid injections, all aimed at suppressing the immune system's inflammatory response.
But between the 1970s and 1990s, researchers like Nicola Maffoli and Jill Cook began putting surgically excised tendon tissue from these chronic pain patients under the microscope.
And the histopathology was shocking, right?
Completely shocking. They found virtually zero inflammatory cells, no neutrophils, no lymphocytes. The condition the uveitis suffix described just didn't exist in that tissue.
So instead of inflammation, what were they actually looking at?
They found severely disorganized collagen fibers, an increase in ground substance, and abnormal neovascularization.
Which means tiny, aberrant blood vessels growing into areas they shouldn't.
Exactly. The tissue wasn't inflamed, it was degenerating. The structural integrity was actively breaking down.
So using anti-inflammatories for a degenerative tendon is literally like throwing buckets of water on a house that isn't on fire, while just ignoring the termites eating the foundation.
That's exactly what it's like. And worse, the cortisone injections were actually inhibiting collagen synthesis, making the tissue more prone to full rupture. The vocabulary literally sent doctors down a destructive treatment path.
That is so frustrating. But this revelation forced a massive field-wide paradigm shift.
It did. The medical community aggressively pivoted to the term tendinosis, meaning degeneration, or the broader umbrella term tendinopathy, meaning tendon disease.
Intentionally abandoning the uveitis suffix to prevent misguided treatments. Because if the tissue is degenerating rather than inflamed, rest is actually detrimental. It doesn't stimulate repair.
Right. The treatment shifted to progressive mechanical loading.
And the most prominent example of that is the Alfredson eccentric loading protocol, right? Published in 1998 by Swedish researcher Håkan Alfredson.
Yes. For chronic Achilles tendinosis, patients perform heel drop exercises, applying heavy load to the tendon while it is actively lengthening an eccentric contraction.
So you're stretching it out under load. Why does that work?
The mechanism behind this is mechanotransduction. That specific type of mechanical stress physically signals the tenocytes within the tissue to upregulate collagen production and remodel the degenerated matrix.
Which is incredible. The Alfredson protocol yielded phenomenal recovery rates, rescuing countless patients from unnecessary surgical interventions simply because we finally understood the underlying pathology.
Right, but understanding that pathology requires seeing these roots, teno, tendino, ligamento, not just in isolation, but as an interconnected architectural system.
Yeah, a tendon doesn't just float in space. It crosses an arthro, a joint. It anchors a myo, a muscle. It is frequently wrapped in fascio, the fascia.
And the fascia undergoes the exact same diagnostic debate we just discussed.
Oh, right. The chronic foot condition, previously universally known as plantar fasciitis, is now widely recognized and treated as plantar fasciosis.
Exactly, a degenerative breakdown of the fascial band.
And because these thick cords are sliding over bone, the architecture includes burso, small, fluid-filled bursa sacs to reduce mechanical friction, and synovo, the lubricating joint lining.
There's also the Greek root for bond, desmo or syndesmo, which gives us the term syndesmosis.
That describes a specific type of joint held together tightly by ligaments, like the connection between your tibia and fibula.
Right. And when extreme rotational force tears that specific syndesmosis, you get what sports commentators commonly refer to as a high ankle sprain.
Ah, okay. The vocabulary maps the physical destruction perfectly. Surgeons actually utilize that same root for the suffix stasis, indicating a surgical fusion or fixation, such as a tenodesis.
Now, the actual connection points present an incredible engineering challenge.
Oh yeah, because a highly tensioned cord cannot just abruptly glue onto a rigid bone, the osteo, or cartilage, the chondro.
Right. If the dense regular connective tissue simply ended and the bone began, the sheer force would cause it to snap instantly at the connection site.
So how does the body solve this?
Through a specialized transition zone called the enthesis. It is a literal masterclass in gradient engineering.
Gradient engineering?
Yeah, the fibrous tendon tissue gradually transitions into fibrocartilage. That fibrocartilage then gradually mineralizes until it seamlessly becomes bone.
This biological gradient dissipates the mechanical stress over a much larger surface area, preventing a sharp stress concentration. It functions exactly like the reinforced rubber sleeve at the base of a phone charger cable, graduating the stiffness so the wire doesn't sharply bend and snap right at the plug.
Exactly. And zooming in on the enthesis completely changed how we classify systemic diseases. Rheumatology actually relies heavily on this microanatomy.
Really?
Yeah. There is an entire category of inflammatory diseases known as the spondyloarthropathies, which includes conditions like ankylosing spondylitis and psoriatic arthritis. For decades, their mechanisms were misunderstood.
But now we know their primary target is not the joint lining, but the specific transition zone.
Right. They cause enthesitis inflammation of the enthesis, which fundamentally distinguishes their pathology and treatment from conditions like rheumatoid arthritis.
So the structural integrity of these tissues dictates overall systemic health in some pretty profound ways. Connective tissue disorders, notably Ehlers-Danlos syndrome, named after Edward Ehlers and Henri Alexandre Danlos in the early 1900s, specifically disrupt the production and structure of collagen.
And because tendons and ligaments rely entirely on the precise architecture of that collagen, individuals with Ehlers-Danlos experience severe joint hypermobility, frequent dislocations, and chronic pain.
And after decades of having their symptoms dismissed by the medical establishment, the mechanical reality of these conditions is finally gaining widespread visibility.
Which is so important. But the impact extends far beyond rare syndromes, too. The natural aging process fundamentally alters these tissues for everyone.
Yeah, as populations age, asymptomatic tendon degeneration becomes a nearly universal human condition. MRI studies of adults over the age of 60 reveal a massive percentage possess rotator cuff tears in their shoulders without displaying any clinical symptoms.
Right. The intersection of aging tissues and our desire to remain highly active is driving monumental orthopedic healthcare costs. Managing the degeneration of the structures labeled by tenno, tendino, and ligamento is undeniably one of the most economically and physically consequential sectors of modern medicine.
It is genuinely incredible how much complexity is woven into the tethers holding us together. I mean, we navigate a bizarre hybrid of ancient Greek and Latin history every time we name them.
We do.
We've uncovered the microscopic reality that tendons and ligaments are essentially identical materials deployed for totally different mechanical purposes. We've seen how vascularity dictates the need for surgery and how a single erroneous suffix tricked generations of doctors into fighting a fire that literally wasn't there.
And, the history of these words is often as visceral as the tissues themselves.
What do you mean?
Well, the most famous tendon of all, the Achilles tendon, permanently gained its modern name through a remarkably dark event in the 1690s.
Wait, really?
Yeah. A Flemish anatomist named Philip Verheyen suffered a severe infection, which resulted in the amputation of his own gangrenous leg.
Oh, wow.
But rather than discarding the limb, he kept it and meticulously dissected it himself.
He dissected his own amputated leg.
He did. His intense, detailed writings from that self-dissection are widely credited with cementing the term Achilles tendon in European anatomy. It permanently linked the mythological Greek hero's one vulnerable heel to this very real, rupture-prone physical structure.
That is just wild to think about. It really stands as a profound reminder of how sterile medical vocabulary is permanently fused with incredibly personal, visceral human stories. So the next time you step off a curb or watch an athlete plant their foot, think about the immense kilonewton forces pulling on the biological cables inside you. Think about the thousands of years of linguistic confusion it took just to name them accurately. Unlike a suspension bridge constructed of static steel, your body's tethers are living, dynamic structures constantly adapting, occasionally degenerating, and, given the right mechanical signals, actively rebuilding. Thanks for joining us on this deep dive. Keep questioning the words you use and the hidden structures that hold you together.